You can advance here, Marwa. All right, so as I was alluding to, we have Marwa. Please don't let me butcher your last name. Elnagheeb. All right.
Yes.
So Marwa is a Sudanese American med student at the University of Utah. She earned her bachelor's in biology and a master's in public health at University North Carolina at Chapel Hill. And her background is in maternal and child health, genetics, and epigenetics. Her research experience is in genetic variation and epigenetics, as I indicated, maternal nutrition, and maternal and child health disparities. She's been very instrumental in uh, works this year and last year for BPOU and SNMA. So thank you so much. And much of this presentation is all Marwa, and you will see it tonight. And then, of course, next is the old man in the room. That would be me, Dr. Richard Ferguson. I have a couple roles. I am the founder and president of Black Physicians of Utah. Our goal and purpose is not only community education, but to create more Marwas, Khadijas, Michael Anafis, Tyler Thompsons that are on the call so we can have future physicians to address health equity, future Black physicians to address health equity in Utah. In my day job, I wear a hat as a chief medical officer for Health Choice Utah. All right, next slide and take it away, Marwa.
Great. Thank you. I'm going to turn off my video temporarily just to preserve my bandwidth, but I'll start with just a general overview of colorectal cancer, starting first with where it occurs in the body. We have our large intestine, which is comprised of the colon, rectum, and anus, and it is also sometimes referred to as the large bowel. Its function is to absorb water and electrolytes from food and to eliminate feces. And when we talk about colorectal cancer, in plain terms, it's the uncontrolled growth of abnormal cells in the colon or rectum, and it's currently considered the second most common cause of cancer death. Now, this is a helpful infographic from the American College of Gastroenterology, just giving us some key facts about colorectal cancer. One, that it is in the United States, the third most common cancer in both men and women, but it's also one of the most preventable types, which we'll talk about a lot today. The risk is about 1 in 23 for men and about 1 in 25 lifetime risk of colorectal cancer for women. And each year there's an estimate of 150,000 new cases and an estimated 50,000 who will die from colorectal cancer. The reason why there has been a lot of discussion about colorectal cancer as of late is because we're seeing it appear more and more among young people. So it's been estimated that people born around 1990 have twice the risk of colon cancer and 4 times the risk of rectal cancer than those who were born prior to 1950. And so it's been posited that this could be possibly due to trends in unhealthy diets, sedentary lifestyles, but the reasons are complex. But we're seeing from 2012 to 2021 that while the incidence has been decreasing, it's mostly decreasing among older adults, and the incidence is actually increasing in people who are younger than 50 years old. And so in the media, many of you may be familiar with these 2 individuals who died pretty young from colorectal cancer. We have Chadwick Boseman on the left, died at 43, and then Natalie Desselle-Reid at 53. And studies have shown that Black individuals have a higher risk of being diagnosed and dying from colorectal cancer compared to other racial groups. So we see in this study here, that's a 20% higher incidence compared to non-Hispanic white and 50% higher than Asians and Pacific Islander individuals. But
And I was just going to point out that for Chadwick Boseman, although he might have passed at 43, he was battling colorectal cancer for several years. So to the fact that he was definitely well under 40 years of age, and thus bringing more credence to of it increasing in those of younger age groups. Sorry, please go on, Marwa.
no, that's helpful. And But we have seen cases across all age groups, all races and ethnicities, and that's important to keep in mind that colorectal cancer doesn't discriminate. We can see here on the bottom, we have Pelé, a Brazilian soccer player, died at 82. Vince Lombardi in the middle, Green Bay Packers coach, died at just 57 years old. And then Kirstie Alley here died in her early 70s from colon cancer. But again, there are racial and ethnic disparities, but the reasons for that are quite complex. So that brings us to a graphic here of potential contributors to disparities in colorectal cancer. And we can break it down into three levels. The first is patient level factors. And so you can see several examples here, one of which we're trying to address today with this talk, which is knowledge of the disease or health behaviors and lack of awareness about screening guidelines or risk factors. People may not know the importance of regular screenings. All of that can contribute to disparities in colorectal cancer incidence and mortality. Next, we have provider or health system factors. You can see several listed here. One that is important to note is just marginalization in medical decision making or discrimination within health systems. We see that with African American patients in colorectal cancer care, that they may be diagnosed at later stages. They may face implicit bias from providers, be delayed in diagnosis or get less aggressive treatment. So the more knowledge of the disease and will help patients to advocate for themselves as well. And then with public policy factors, again, we can think of healthcare system inequities. We can think of limited access to funding for colorectal cancer screening programs in certain areas. And that's something that's going to be discussed more later on by Dr. Ferguson with respect to Utah. But collectively, these all contribute to racial disparities, whether it comes to prevention, detection, treatment, or surveillance. Those all come all together to contribute to differences in colorectal cancer mortality.
And if someone wants to put in the chat, just because it is so prevalent, if you've actually been impacted, if you know someone close to you, relative, friend, that actually has been diagnosed with colorectal cancer or possibly as contributing to their demise, just so we can kind of see how prevalent it is, if you're okay sharing in the chat,
The
please.
biggest takeaway I think from today is to remember that colorectal cancer is preventable. We know that screening reduces mortality by both decreasing incidence and also increasing survival. And the 2018 American Cancer Society, their screening guidelines recommends that adults ages 45 and up undergo regular screening. So previously that was 50 and up that was recommended, but that age has been lowered. Another important study highlighted the importance of early screening and the impact of that, not only on incidence of colorectal cancer, but those racial disparities that we previously touched on. So you can see here in this graph, this is data from a screening program that was piloted in 2006, indicated by this vertical line here, through 2007, and then it was fully implemented in 2008. And so you can see the kind of percentage of non-Hispanic white persons and non-Hispanic Black persons who were up to date on screening between 2000 and 2019. And the first year of the program, we can see some changes as the program progressed. And with more colorectal cancer screenings, we can see the incidence not only go down, but the disparities in incidence of colorectal cancer and death from colorectal cancer between non-Hispanic Black and non-Hispanic white persons decrease. So with more equitable delivery of screening and polyp removal, more timely treatments, we'll see decreases in the incidence of mortality, and then eventually we see that decrease in the difference in mortality between Black and white patient groups.
All right, it is quiz time. So remember, once again, thank you for sharing, Junior. It is quiz time. So make sure that whoever answers first, you then also follow up with your email address. Okay, let's go to the first quiz.
Right.
Which of the
So which of
following, oh, please go on.
is associated with a higher risk of colorectal cancer?
Getting plenty of answers for B.
Yes, and that is the correct answer. So good job to everyone.
All right, Gina, what is your email address? Thank you.
All right. So now I'm going to move into some more scientific discussion about understanding colorectal cancer. First is, what is a colorectal polyp? And so a polyp is a small clump of cells on the lining of the colon. Most colon polyps are harmless, but some of them may develop into colorectal cancer, which are often fatal if it's not found until later stages. So not all polyps will become cancer, but almost all cancers start as polyps when it comes to colorectal cancer. So how exactly is a polyp formed and how does that progress to colorectal cancer? So to explain this, I wanted to use an analogy, the neighborhood analogy, I'll call it, where we can imagine that our colon is this peaceful neighborhood and the cells that are lining the colon are homes. There's an important gene in our body called APC, and a mnemonic you can use to remember that is a police cop, who we can think of as the neighborhood watch captain, pictured here. So the APC gene, it keeps an eye on things in a neighborhood, making sure that everything stays orderly. But if the APC gene mutates, it's like firing a neighborhood watch captain. And so as a result of that, we have this abandoned house that appears in the neighborhood, or this small polyp that appears in our colon. But there's still one other neighborhood watch captain, thankfully. But if the second copy of the APC gene mutates, it's like firing the only other neighborhood watch captain. So the condition of the abandoned house worsens, and we see that the polyp grows to be even larger. Now, with stage 0 colorectal cancer, we have the formation of a precancerous polyp. So with this, we can imagine the house is further run down, but the damage, the abnormal cells seen here in white, are contained within the property still, or the mucosa, which is our innermost lining of the colon wall. And then progression to stage 1 colorectal cancer involves formation of an adenocarcinoma. So with this, we can think of this as the home becoming a hotspot for troublemakers or cancer cells, again here in white. And that damage starts spilling over into the front yard or the next layer of the colon wall, the submucosa, officially making it a dangerous situation or malignant. So what do we have here? We have a polyp that forms, grows, and then progresses to early stage colorectal cancer. And it's because of a mutation in both copies of the APC gene. Moving on to stage 2 of colorectal cancer, we have another important gene in our body called KRAS or KRAS. And we can think of this gene as a strict but reasonable parent, and it controls how fast cells grow. So parents making sure kids follow curfew, don't get too rowdy. But if the KRAS gene mutates, it's like the parents stop enforcing any rules, and now the teenagers take over the abandoned house. They're staying up all night. They're inviting friends over and making things worse. So with stage 2 colorectal cancer, we can think of this as the parties are spreading beyond that front yard. So it's moving past that submucosa into even deeper layers of the colon wall. And so we have this tumor that has outgrown its original boundaries, and it's making it even harder to control. And that's because we've now accumulated another mutation, not only in APC, but also the KRAS gene. Next, we have stage 3 colorectal cancer. Another important gene in our body is TP53. A mnemonic you can use to remember this is the 53 police that shut down problems. So it's a gene that acts like the local police force, stepping in when things get out of hand. It either stops bad behavior or removes the troublemakers completely. But if TP53 mutates, it's like the police deciding not to respond to any more 911 calls. So now there are rowdy parties throughout the neighborhood with no consequences. So with stage 3 colorectal cancer, the chaos has spread to nearby streets, or the cancer has grown through not only all muscular layers of the colon, but has moved into lymph nodes. And those lymph nodes are an important part of our immune system. And entering into the lymph nodes can mean that it will eventually reach other organs. So without law enforcement, the situation escalated dramatically, putting other areas or the organs at risk. And again, we have even more accumulation of mutations and genes in our body. And then with stage 4, the final stage of colorectal cancer, we have an important gene, DCC, and we can think of it as the laws that keep those parties contained. And the DCC gene is deleted in colon cancer and acts like zoning laws, speed bumps, gates that prevent problems from spilling over into other areas of the city. But if DCC mutates or is lost, it's like removing all of those neighborhood gates and barriers, allowing chaos to spread freely to other parts of the city. So the cancer cells have broken through the colon wall. They've invaded distant organs, which is called metastasis. And an example could be to the lung, it could also be to the liver, among many other organs. But the outcome is that the cancer has spread beyond the colon to distant sites, making it even harder to control. And again, we have this even longer list of accumulated mutations and genes in our body. Not an exhaustive list, and it can definitely vary from person to person. And that is important to keep in mind. So in summary, we see all of these stages of colorectal cancer, and it's important to highlight this because screening with polyp removal can prevent that colorectal cancer from developing before it starts. We know that most early stage polyps do not produce symptoms, and it's important to have regular colorectal cancer screenings, and again, starting at the age of 45 or possibly even younger, depending on risk factors, which we'll discuss.
So,
Right.
Marwa, there's a question in the chat that I think is a great one. And
Okay.
it is it more common for colon malignant cancer cells to spread via lymph nodes rather than blood vessels?
So they're interconnected. So the lymph nodes, they will eventually drain into veins, and those veins will go back into the heart, and then that blood will pump out to the body. So it's a route that the cancer cells can potentially take via the lymph nodes, eventually into the bloodstream, and then eventually to other parts of the body.
So I think something to consider, Michael, and a great question is before it even hits the lymph nodes, is there blood supply to that part of the colon? And the answer is yes. So it's actually small amounts of cells, but we still have other parts of our body that are defending and killing those cells before they can take catchment and grow in mass elsewhere. But once it's in a lymph node, which is a larger system, that they can kind of stick there and continue to multiply before they're caught elsewhere in the body when it's just through capillary spread or going to a deeper vessel. So it's almost kind of stating, is there a way? Oh, Gina wants to go back to the previous slide.
Yes, I can do that.
Yeah, sure. So the answer is yes to both, and it is often contacting some aspects of your blood supply before it even hits the lymph node. All right. And mind you, once again, this will be provided. The presentation will be recorded in its entirety and posted on YouTube. Okay, next quiz question. A mutation in which of the following genes is involved in the first step of colorectal cancer development? Okay. I feel like sometimes, I wish I could put a little hold switch on the med students that are currently present. Give the public some more time. But please advance to the next slide.
And
And
yes,
it
the
is
answer is APC.
all right. So way to go, Michael. Good on you. And we will make sure. Can you throw there we go. All right. I know I have let me just add that here. And it looks like, am I up next?
After a couple more
Oh, yeah,
slides.
that's right. That's right. You're still
Yeah.
on. You're still on.
Now, I did mention earlier that the recommended age for colon cancer screening is starting at the age of 45. But with certain risk factors, that age may be even lower. So listed here are some risk factors, and as you go up here on the left, that risk of colorectal cancer increases. So it's very important to get your family history. And the highest risk for colorectal cancer among these factors comes if you have two or more first degree relatives. And it's important to note that if, for example, your first degree relative was diagnosed with colorectal cancer at, say, the age of 45, then it's recommended that you get screening starting at 10 years prior to that age at 35. So 45 is an important number to keep in mind, but it may be even lower for you depending on your risk factors or family history. Something that has come up a lot lately is the effect of diet, particularly red meat consumption and processed meat consumption, its impact on colorectal cancer development. And so that's specifically about 100 grams or more per day. We can think of that in terms of about the size of the palm of your hand or the size of a deck of cards. But we also have some factors that help to decrease your risk of colorectal cancer. Um, First, we have a diet high in plant foods, dairy consumption, in particular, adequate calcium intake has been associated with a decreased risk of colorectal cancer, and physical activity. And there are a lot more studies that posit other potential foods or factors that can lower your risk, but there isn't really a consensus on those across all studies. And the other major risk factor I wanted to bring up is with age. And so we can see here from this particular study that we have the incidence of colorectal cancer increasing pretty consistently with older age, doubling, and then maybe increasing by about 75%. And then we get to this age group here of ages 50 to 54 versus ages 55 to 59. And we see there's only about a difference of 15%, which is much lower than we've seen in the other age groups. And of note, we know previously that the recommended age for colorectal cancer screening was 50 years old. And so this is some older data, but it's likely that is the reason to have an influence on that decrease in incidence between those two age groups. And we see that we have a bit higher incidence here at 50 and 51 when getting first colorectal cancer screening. So maybe this is the time when they're catching cancers that have been developing for some time. And then we see it drops off and kind of varies and then increases again.
And actually, Marwa, I just want to make a point, and because this is something that impacts all of us, because often food is very much cultural. And let the slide before that, not the title slide, about risk. There we go. So one thing that we are sometimes there's greater incidence of use in Black and marginalized communities is sometimes when addressing type 2 diabetes, smoking tobacco, and obesity. And so even doing things such as trying to reduce one's weight, increasing cardiovascular health, all things that BPOU encourages with its activities and much of our education here. But the other thing is processed meat. Everyone loves a charcuterie tray. Everyone loves a charcuterie board. And that's often when many people are getting exposed. And the thing is, I think sometimes we are not sometimes as mindful of our intake, particularly med students and other students that may be on the call. Because if it's set out kind of for free and it's at an event, and because we do a lot of this when it comes to holidays and parties and such as that, the only thing is we have to be a little bit more mindful because this increases our risk of inflammation. And then when you have enough inflammation occurring in your colon, you're going to increase that incidence that those protective genes are going to lead to errors and can cause precancerous lesions to develop. So once again, this will be available, but these are ones that I just kind of want to highlight that is sometimes increased risks of incidents that we do culturally because food is love and we're not as mindful. All right. So, Marwa, just so we can be good on time and I won't mess anything up, I'm gonna let you continue to drive. Sounds good? I want to
Would
make
you
sure
like
to
to
provide time.
present? Okay.
Yep, great, great. So, what we wanted to discuss a bit here is actually genetic testing for hereditary cancers. So research has shown that about 5%. We will get to that, Gino, as soon as we get through the genetics section. Or if you want to respond to that, Marwa, in the chat while I'm presenting, I think that's fine. But hereditary risk factors. So, research has shown that around 5% of colorectal cancer patients have a high risk of inherited mutation, with an additional 5% having mutations linked to moderately increased risk. Once again, kind of highlighting this importance of genetic testing. And there are multi-gene testing panels, particularly the company here that we are recognizing, but there's more than just that of myriads in their MyRisk test. But MyRisk is a type of test for multiple genes associated with various hereditary cancer syndromes, and it focuses on 11 primary cancer sites. And actually, if you open the test, it'll actually have a anatomy of the body, and it screens for kidney, heart, liver, colon, even brain cancer. But it focuses on 11 primary cancer sites, and it's a comprehensive overall cancer risk for hereditary cancers. So if we understand the majority of breast cancer, if people remember a presentation that we had probably last year, it's it is not as highly correlated. What BRCA1 and 2 are those particular genes that people may be familiar with. That's a high correlation with inheritance, but for the most part, it's random. It's just going to be 1 in 8 women, and then so it's all these other multi-factor risk, other risk factors outside of genetics that contribute to also a cancer that's a leading cause of death or leading cancer cause of death. And then personalized risk management, it identifies genetic mutations, and this is a tool. It aids additional information to your healthcare provider for when making a decision of, do I need to get screened a little sooner? I notice that I'm positive for Lynch syndrome, or I have higher risk of a particular syndrome, or I have a higher likelihood of having an abnormality with one of the genes she mentioned earlier. This can be used with family history and this initial genetic screening to get even more specific testing. So next slide. So as I was alluding to, Lynch syndrome. So Lynch syndrome, this is, or the MLH1, and I won't get us too bogged down with the jargon here, but in Lynch syndrome, the genes responsible for fixing DNA errors, like a repair crew, they don't function properly, and it causes cells to accumulate, causing cells to accumulate damage and increasing cancer risk. Younger onset cancer risk, particularly individuals with Lynch syndrome, often develop colorectal cancer at a younger age. So when you hear about people having symptoms like, well, 45, getting him waiting to get screened at 45 wouldn't have caught him, because there's a higher likelihood that they have Lynch syndrome as a contributing factor or a hereditable form of colorectal cancer. So it's seen more common in those people that are getting diagnosed under the age of 40. They more likely have a family history of colorectal cancer. But particularly, about 8% of adults under 50 are diagnosed with this condition. And the importance of screening, which we want to kind of drive home here. And eventually, I think BPOU may actually offer an opportunity for people to at least get swabbed and be able to pay for the test yourself, or you can get this test kind of held by Myriad, and then eventually they will run it through your insurance to get it covered. But and I will get to that in a little bit of a later date. I'm getting ahead of myself. But up to 82% of people with certain Lynch syndrome mutations can develop colorectal cancer. That's pretty high. So there's a benefit to regular genetic testing and proactive screening. And you can control your data. I know recently there's a certain company, 23andMe, that's gone bankrupt, and people are worried about their genetic data being out there. You do have control over this. Myriad does not keep it. All right. Next slide. So what I want to emphasize here with familial adenomatous polyposis, or FAP syndrome, FAP often leads to a growth of hundreds or even thousands of colon polyps. Sometimes it's too bad we didn't add a photo of it here, but it looks like little tendrils that are throughout your colon. And they typically appear between ages 20 and 39. These are the folks that will definitely need genetic screening, but additionally more regular colonoscopies because there's such a higher incidence of one of those polyps becoming very aggressive and turning into adenocarcinoma of the colon. So one thing to kind of emphasize here, that APC gene acts like that neighborhood watch for cell growth. And in a FAP mutation, this gene prevents it from controlling abnormal cell development. So once again, high risk of cancer if you have the FAP syndrome. And without treatment, there's a nearly 100% chance that all of these will progress to colorectal cancer. All right, next slide. It is quiz question time. All right. Well, dang. Did someone see it in advance? Which hereditary cancer can cause several colorectal polyps at a young age due to a mutation in the APC gene? Marwa, you can advance. Right. So I think right there, I believe it was Michael Richard. You were correct, sir. So throw your email there into the chat, and then we will collect that. I think we've got probably two questions left, maybe one or two left. All right, so let me continue here. So one thing is, what are the symptoms of colorectal cancer? Let me just copy this. Hold on a second. So what are the symptoms? So the key here is early detection being key. Most early colorectal cancer symptoms, there essentially are no symptoms. Thus, once again, the importance of genetic testing, but really trying to make sure that you are able to get in and start getting screened. And if you even if you delay with wanting to just get a Cologuard or a fit test, start by 45. That's what we are really trying to stress here because remember with blood, so bowel habits, and I like this acronym quite a bit, but because people are often asymptomatic and the symptoms can be quite vague at times because they can often mimic many other things that can cause discomfort, particularly with abdominal pain and cramping. Diarrhea and constipation, many of us will dismiss for some time, particularly us men, us black men will dismiss because we'll say, well, I'm sure that's just from the beer I had, or it's a dietary change, or I went traveling on vacation, and they'll diminish. And then, of course, one that's common that many people stress with any big C, and that being loss of weight unexpectedly. And then, of course, early discomfort or discomfort with eating. So feeling early satiety or feeling full. So yeah, early satiety or discomfort after eating. So this can sometimes, when you're starting to have the symptoms of particularly weight loss and that of early satiety, you're often at stage 4, in my experience of diagnosing people, or when they're presenting in the ER. Usually there are some other glaring symptoms that are in denial that precede that, but they often started having symptoms even a year, 2 years in advance. So sometimes it shows, once again, with screening, you have time for something that actually has not only can screen, can diagnose and treat all at the same time. All right, next. So colonoscopy prep. This should not be a reason. And I will repeat once again, as someone that is taking care of folks that find this uncomfortable, but what's even more comfortable is your family standing around you in a box for something that you could have prevented. So once again, clear liquids are key. So sticking to a clear liquid diet before the procedure helps ensure the colon is as clean as possible, improving visibility for the doctor. If you have to go back again, that's okay, especially if this is a covered procedure. And many people are going to work the next day. You can do a prep, you do your 9 to 5, you prep in the evening, and then you're ready to go and get your test by, the afternoon of the next day. So combination of laxative products, particularly just Dulcolax, Miralax, works to fully empty the colon and gives you a more accurate colonoscopy. And then I often say plan ahead. People will be a bit sleepy. They give you a mild sedative. I just, as someone that had their colonoscopy 3 years ago, the prep, a little bit of cramping. I think I lost a little weight from that, but went in that following late morning. It by the time they give you your sedation, I think the procedure took all of about 15 minutes, and then the grogginess was gone within an hour. But do plan ahead. Have someone that can at least come and pick you up afterwards. All right, next. Now, the colonoscopy and polypectomy. So this actually goes through a bit of the procedure itself. So it's where the doctor takes the scope, they go in, long flexible tube. They do this so frequently. They're quite good at it. The risk of perforation, because that's sometimes people feel, I don't want to go in there and have them at risk of going through a colon. It's so rare. Less than 0.1% are at risk for a colon perf. And even then, they often detect it and repair it within 24 hours. So I've not had anyone in the thousands of ER patients that I've seen coming in with a acute perforation of their colon as a result of colonoscopy. So once again, not a reason to discourage oneself from going to get this often life-saving screening. So what to expect? As I said, you get a little bit of IV anesthesia, you have mild sedative, maybe something for pain. Most of the discomfort is just from the gas and the air being, I would say, placed into your lower colon so they can better visualize, so they kind of expand it. Other than that, you release it. You might be releasing it for a little bit when you get home as well. But the key is it's slowly, once they reach the small intestines, they remove polyps, they send for testing. And then, of course, if they see a polyp, they will remove because there's all immediately great suspicion as an abnormal cell growth. And the removal of polyps, 90% curative for colorectal cancer cases. So why would we not want to go? It's a little bit of discomfort the night before, but you can spend a higher quality, longer life and better quality of life with your loved ones and your family. All right, next. So the recovery, as I said, it's not recommended that you drive home, get someone to pick you up, but the recovery is often pretty quick unless you have possibly liver disease, which they may use a variation in sedative. Bleeding risks. I've seen this more often in that someone's internal hemorrhoids are more agitated by the scope going in. But of course, there could be a mild amount, especially if you are on a blood thinner. Usually some of that is held before the procedure, or if you had to get a polypectomy. But they're usually not, once again, perforating or anything rupturing as a result. Most of the time when I've seen some blood that people have had after colonoscopy is from irritation of their external or internal hemorrhoids. All right, next. All right, I think you're on now, Marwa.
Yes. So a bit more information about the screening tests for colorectal cancer. I know we just discussed the colonoscopy, but there are other tests, starting first with stool-based tests. We have the fecal immunochemical test or FIT test, guaiac-based fecal occult blood test, and then Cologuard or multi-targeted stool DNA. And so this chart here just outlines what each of the tests entail and their differences. The FIT test tends to be the most sensitive of the three, has a low cost, can be done every 12 months. And so in that period of 10 years between colonoscopies, this is a test that could also be done. But it's important to note that not only the FIT test, but other stool-based tests can miss many polyps, particularly those really small ones that are not bleeding yet. And so it doesn't substitute for a colonoscopy. If you get a positive test, regardless, you'll still have to get that colonoscopy screening. And then some other visual examinations. So in addition to the colonoscopy, CT colonography can be done. That's imaging of the colon with CT, no sedation required, can be done every 5 years. But of note, it's not covered by all insurance plans. But it is fairly quick, not many complications, don't have to do any preparation. But again, a colonoscopy will still be necessary afterward. And then last, we have the flexible sigmoidoscopy. And this is similar to a colonoscopy, but it is only evaluating part of the colon, this lower part, and then also the rectum, which also happens to be the region of the large intestine where many polyps and colorectal cancer develops. But again, it does have the disadvantage of not examining the entire colon. It can be done every 5 years, but again, copay insurance costs can vary compared to, say, a colonoscopy that is typically covered by major insurers, even though more expensive. But again, this last test will still require a colonoscopy to be done, albeit the preparation is less intense and it is quick.
All right, I think we're up for our next quiz. So, which colorectal cancer screening test detects blood in stool using antibodies against hemoglobin? See answers coming in. So I'm wondering if people are just doing it randomly to get a card, unless you have access to the presentation. All right, Marwa, are you gonna please advance? Okay,
Yes.
so the winner is Marvis Roland. Please send your email down in the chat. Right. So I would like to now go over. So it might. So there's some animation here. So if you want to click through. All right. So what I would like to go over with people here is the Utah One Health Collaborative. So this is an initiative that it's a not public, private nonprofit that Governor Cox initiated in 2021, and it's his 15-year plan to create a more affordable, high quality, trusted healthcare system in Utah. He wants to put Utah as the leader, not only in the Mountain West, but in the nation. Next. And it's guided by various stakeholders and payers, such as myself. So a member of people, go back, please, on the states, so insurers, you have community-based organizations, you have other nonprofits such as Project Success that people may be familiar with, and you also have clinics that are engaged for various issues that are a priority, from diabetes to breast cancer screening, but also colorectal cancer screening, because right now the wait in Utah, because we don't have the largest density of actually specialists or physicians based on our population size, can be quite long. And also there are sometimes discrepancies on what an insurance will cover. Will they cover the screening if they have symptoms? Is that now diagnostic? So there's some confusion. In the end, it's leading to barriers for Utahns to actually get colorectal cancer screening. So that's what this initiative is here to address. Next. Here are some of the stakeholders. As you can see, it's Optum. We have FEP, which is the State Employees Insurance Plan. We have Regents, Blue Cross Blue Shield, of course, Health Choice Utah, University of Utah Health Plans, and Utah Medicaid. In common spirit, so we have health systems that are engaged and involved with this as well. Next slide. So, as we can see, we kind of went over. It's actually the second leading cause of cancer-related death in the U.S. And we went over some of these stats a bit earlier, but early detection, curative in 90% of cases. But really what I want us to zero down in is the rate of Utahns up to date with their recommended screening has dropped. In 2020, it was 74%. And then in 2022, it's 59.4%. We have yet to recover from that. And that was due to such a backlog when so many things had closed and reduced access as a result of the pandemic. We're still trying to recover that. So right now it's 9 months to a year. If someone is not as already established with prior screening, 9 months to a year, if you're possibly also with the non-VA health system, because that sometimes is a much smaller population, 9 months to a year before you can get into a GI doc to get a colonoscopy. That's far too long. Far too long. You can go from stage 1 to stage 3 within that time. So the goal here is increase access to colorectal cancer screening, right time for eligible Utahns, and to unify these efforts. Next. And of course, empowering patients. And then Once again, I'm emphasizing here how we as payers are involved. So expanding access and then looking at home-based options. So remember what Marwa showed a little bit earlier there about the fit test, because if you're negative on your fit test, you've got a little bit of time. And then you can actually repeat that fit test if you're unable to get into a colonoscopy in a timely manner. However, the fit test, if it's negative, you then got another year or two before another year before you can take it again to then yet determine, all right, I still have some more time to get in for my colonoscopy. So we feel that if we can actually narrow down those at risk with a fit test, it will actually benefit more people to narrow down who should be a priority to get in next for their colonoscopy, as opposed to just being based on age. Next. So once again, this is a collaboration, primary care. It involves quite a bit of member outreach. We actually had a small social media campaign that us as health insurers were supportive of with Utah Health Collaborative putting together. I don't know if it popped up into people's feeds, but it might have. But once again, we're trying to streamline coverage, and particularly streamlining coverage because if some people hear that said, oh, well, my insurance covered and I had to pay 20% of the cost of the colonoscopy, that's not unusual. But then you have some people where they said, well, my doctor said it's covered, but if they find a polyp, they then charge extra now because now they're sending off for pathology. They're now having to pay a pathologist. They're paying the lab. And now you get a bill when you were told before you went under the anesthesia and you got your prep and you took time off from work that you wouldn't have a bill. That's some of the stuff that we're working out. All right, next. And then once again, we're trying to get our health systems to expand their capacity so that people don't have to wait as long. And once again, targeting underserved populations to improve this sort of timely CRC screening and follow-up. And then once again, promoting home testing as a first line option. We don't have to just sit and wait and complain that I can't get in. No, you can go and actually, you'll either have it sent to you or you can go and request, hey, I want this fit test and I would like to send that in, and you get your result within 2 weeks or less. So taking action, next. These are some of the resources, so please take a second to scan. And we will have resources as well on BPOU's website that'll be updated. All right, next slide. And then here is actually some of our upcoming events. Particularly our spring awards, where we will recognize medical students, pre-meds, and docs, very much like Marwa tonight. They are the future of Utah. And so any opportunity we have to elevate and celebrate and recognize their accomplishments, we will, because we want to normalize presentations and seeing us taking care of not only those in the Black and underserved communities, but just Utahns in general. All right, I will now open it up for questions. And Marwa, if you want to learn a little bit more about BPOU. But yes, any questions for people? And Marvis, let me get your email address here. You'll probably get all these tonight. Anybody inspired to become a GI doc as a result of this session, since it's in high demand? Let's see. And you can come off camera at this. I mean, not camera. You can come off of mute. You don't have to necessarily be in the chat unless you're in an area where you can't speak easily. Will there be any more sessions on colorectal cancer if there's a newsletter or mailing list? Yes. So if people want to go to our, an easy way to sign up for our mailing list, and I'll show you here. Let me just bring up our screen. So I'm going to share here for a second. If people want to sign up, I'm on the wrong screen. I think, what screen am I showing? What do you see? Everybody see Dr. Deckett?
Yes, we do.
Okay. So
Yeah.
if you scroll all the way down to the bottom, this is how you sign up for our email list. This will immediately get you added to our MailChimp that we have at this time going out almost every 2 weeks. So our next one will be, oh wow, it'll be out by April 1st, April 2nd. but we also archive our old newsletters. So if you go to our About section, and then you can see our old newsletters and this will give you a link to older presentations, articles that we've created specifically for the community. We put a lot of time and effort into our website and to actually be a resource for the community. So we actually have a resource page. We actually need to do one probably just on gut health. So some of the resources that were on the resource screen here tonight will be made available um, probably by the April newsletter because we need to update it. But yeah, great question.